Well, isn't this a great segue right into psychopharmacology? After we talked about the cannabis for a while. So, how many of you love drugs? No hands go. Caroline, no hands went up. All hands should go up, right? I'm going to take a wild guess that all of you have taken drugs. Because all that a drug is an exogenous substance that you've put in your body that's had some effect on the way your body works. How many of you have ever had caffeine? That's a drug right there. You're all drug users. We have been drug users for, well, probably since before we were a species. They actually found, this is a cool story. Sean, I think you're going to find this interesting because I think you are a guy who chews on bark for some reason. And so you're going to like this bark chewing story. They found this a Neanderthal jaw recently that had like residue, like remnants of some plant substances, like wedged in between his teeth, right? And some of that was willow bark, right? And willow bark has like salicylic acid in it, which is an ingredient. It's a pain reliever, right? So you think, okay, this guy's just chewing on bark. That doesn't really tell me anything. Interestingly, he had an abscess. He had a toothache, yeah. So he was chewing. This is pretty fascinating that they were using medicines and drugs as a Neanderthal, right? I mean, that is just mind-blowing to think about sort of the intellectual capabilities of this species that we've kind of just written off as just dumb browbeaters.
So we're no aspirin, salsifas?
It is. It's the same, yeah. Yeah, so this guy was taking like prehistoric aspirin, which is pretty fascinating, right? If I put you guys out in the woods and I kick you in the teeth, how many of you are, I mean, I'm not just going to leave you in the woods. I'm going to do something else mean. How many of you are going to know to go like chew on a piece of bark? Sean, I think now you're going to know, right? You might chew on the wrong kind of bark and die from being poisoned, but give it a try. See, wasn't that a fascinating story? It was. I don't know. I found it really sort of mind-blowing. What are we going to talk about? We'll talk a little bit about psychopharmacology, drug action, and then we're going to get into specific neurotransmitters and neuromodulators. We'll talk about how those guys work. All the drugs that you take are really, if they have some sort of what we call psychotropic effect, right? They're just going to be mimicking things that you make inside your body normally, right? So they're going to be sort of augmenting or reducing the effects of specific neurotransmitters. All right, so what is a drug, right? And had you known this ahead of time, you might have all said you love drugs. Drugs are just exogenous chemicals, and they alter the function of cells. That's simply all it is, right? So when you take a pain reliever, that's a drug. When you take caffeine, that's a drug. I mean, it's going to have an effect on your cells, right? On some cells in your body. For our purposes, we're going to think about what are kind of the behavioral effects of that, but we also want to think about the physiological processes. And those are what we call the drug effects. Slightly different, Jacob, than the site of action. That's just where those drug molecules are going to interact with whatever molecules in your body that you have, and it's going to affect those biochemical processes, right? That may not be the same place that you see an effect. Like you may the site of action may be one place, like you think about maybe someplace in your brain, and then that's going to increase your heart rate, right, which is going to increase locomotor activity or something. All right. Really, there are 4 things you need to think about when you take a drug, and those are what we call pharmacokinetics. How does that drug move through your body? How is it absorbed? How is it distributed? How do we metabolize that so it's no longer active? And how do we get that out of your body? Okay. 2 of these are quite short answers. One of them is a very long, complicated answer I'm not going to give you because I don't think you'll enjoy it. And then the other answer we will spend some time on. All right. So routes of administration. How are we going to get this drug into your body, right? You've probably heard of most of these. Most of you have probably taken drugs through a variety of these methods, right? Because they're fairly common. To think about this, we should think about what's the step after administration, and that's going to be distribution, right? And this is a very short answer. How do we distribute drugs throughout your body? We do it in blood vessels. It's that simple, right? We need to get the drug into your blood supply. Okay? Once it's in your blood supply, it'll go wherever it belongs, because your blood goes everywhere, so the drug will go everywhere, and it will have an effect wherever we need it to. It's that simple. Now, there's a special thing we need to do if we're trying to get into the brain, and that's we have to bypass the blood-brain barrier, right? Did we talk about that? Okay, so we have to keep that in mind. We have to be able to get past that blood-brain barrier. And for those things, they're going to be lipid-soluble. We'll talk about that in a moment. So, hey, what's one way we can get blood or get drugs into your blood supply? Well, we can do it through an intravenous injection straight into your blood. That's easy, right? That's great. It's super fast, so that's awesome. The problem with it, though, Rosie, it's super fast. And if you are allergic to this particular drug, we are very sorry. Because we probably did not have time to give you an antidote or reverse that action, right? If you take a drug through another route that's a slower uptake, there are things we can do, right? If you take a drug through oral administration, think about a pill, think about a liquid, and it makes you sick, guess what you can do? You can vomit. Or we could pump your stomach, either way, right? Well, your choice. That's like a fun choice, isn't it? You want to vomit or you want us to pump your stomach today? So, oral administration has some advantage there. But IV, it's going to be fast. It's going to get into the blood supply. You may need to give someone a drug through a different route than oral administration because of hydrochloric acid. How many of you have hydrochloric acid? Yeah, everybody does. It's stomach acid, right? And guess what hydrochloric acid will do? Yeah, it's exactly what it does, right? It helps you with digestion, helps break down things. Certain drugs cannot survive that particular acidic environment, and so taking a drug orally might not be a great choice for that reason. So we might give you an IV. You can also take what we call an intraperitoneal injection, an IP injection. This is when we'll just stab you in the stomach, right, in the gut. We're not really targeting anything specifically, we're just randomly shooting you there. There are not a whole lot of human applications for this. So don't worry about like somebody just randomly, you should worry about people randomly coming up and stabbing you in the stomach. But in a medical sense, Adriana, you don't have to worry about that. We're really thinking about lab animals here. For the most part, that's how we'll administer drugs to lab animals. Think about rats, we'll kind of grab them and shake them a little and it's right in the stomach. There are a couple of other types of injections you get in your intraperitoneal, through IP injections, but nothing to worry about. Intramuscular, I'm sorry.
You get that if you're in a coma.
Yeah.
To keep your blood from, to keep you from getting blood clots.
Yeah.
If you're in a coma, they give you that.
There are a few select applications. We're not just, coming in for your regular run-of-the-mill flu shot or something and getting it that way. So I try to avoid all injections if I can, because if you're going to see a doctor and they're giving you an injection, unless it's like a vaccine, it's probably not for a good reason. Intramuscular injection, who's had one of those? Yeah, who had the flu shot? I need to know so we'll know who's going to get the flu and who doesn't. Yeah, so they'll give you that typically like in your deltoid, right? So they'll give you that in the arm. How many of you have had a shot in the arm and it burned? Yeah, so the reason for that is the pH of the injection was different than the internal pH of your body, and so there was some burning sensation there. That's exciting, right? Nobody wants to say if they've had an intramuscular injection somewhere else. The deltoid and the glutes are like the two targets, right? So you get it in the shoulder, you get it in the butt. Those are sort of where we target those. Those are large muscle areas that you can just sort of, even if you were like graduated at the bottom of med school, you know where the butt and the shoulder are, right? Those are pretty obvious targets. They're not. Also works great on little kids, right? Who don't have like a lot of meat other places, right? You can kind of hit them in those meaty areas. I had the rabies injection in my shoulder. That was a fun one. Like 3 times. And then I had to get a Benadryl shot in my glutes one time. I had a wasp sting me in the eyelid and my eye swelled shut. I was a little kid. That was frightening. Subcutaneous, that's going to be below the skin. You can get a whole lot of subcutaneous injections, but you can. We talked about oral administration. Sublingual. Now this is sort of something we should think about. Sublingual and intranasal. Sublingual is different than oral administration though, right? This is an absorption through a mucous membrane, okay? So keep that in mind. We are not swallowing this, right? Whatever you put in your tongue, you're not swallowing it, so it's not going in to your stomach acid. Intranasal is similar. How many of you have ever snorted a drug? How many of you take Flonase? Yeah, there we go, right? If anybody's done Flonase, you're snorting a drug. You guys always immediately go to like the wrong answer, right? It's like, I don't even care if your hand goes up if it was another drug, like Zyrtec. So intranasal is different than inhalation, right? So again, intranasal, it's going to be absorbed through a mucous membrane. We're not going into your lungs, right? For it to be inhalation, you have to get it into your lungs, right? So that's going to be smoking. That's going to be like if you think about like a breathing machine kind of thing, right? Not something that's going to go through the nose. It's going to come in the mouth and kind of you're going to breathe that in. Intrarectal administration, that is sometimes used for like nausea medications. If you're not going to get that through an IV, for example, right? So why might you not want to take an anti-nausea medication orally? Because it comes right back out, right? So if you can't keep something down, they hope you can keep something up, and so you take it intrarectally. Again, that's a mucous membrane. These are actually all kind of similar. Inhalation, again, it's got to get into your lungs, right? You actually have to breathe this in. Snorting cocaine is not the same as smoking cocaine. They're two different routes of administration, right? They work in two different ways. Hey, what about topical administration? It's when you organize things by no. This is when you rub something like on your skin. How many of you have used Icy Hot? Yeah, Icy Hot's pretty common. Lidocaine, there are a few other things. Benadryl, right? Sometimes comes in like an anti-itch cream, right? That you might rub on. It's the same thing. It's a bit different than transdermal. Okay. We think about transdermal administration. We're thinking about like patches, right? So nicotine cessation patches, hormone patches, right? That's kind of transdermal stuff. These last two are ones you should avoid at all costs. This is when something is so bad, we just have to stick it straight in your brain, right? And so if you're getting an intracerebral or an intracerebroventricular, which is going to go in your ventricles, injection, then you know you're in some serious business. That's when we need to really reduce brain inflammation. This is when you have some infection in your brain, and we really need to. We're not going to run the risk of going somewhere else. The other thing that might be a problem is, again, if we're trying to bypass that blood-brain barrier, right? If this is a drug that doesn't get through the blood-brain barrier very easily, but we need it in your brain, okay, we can try to do that through one of those methods. This is an interesting sort of graph, just to give you an idea that why is it important to think about routes of administration? Because the peak in concentration is different. How long that concentration stays high is different, right? So this is cocaine. There are many ways that you can administer cocaine, right? So this is a good example. You think about an IV, and by the way, these units, you don't have to worry about them. Let's just assume they were all adjusted because they're different routes of administration. They're adjusted, Jordan, for kind of that same size or concentration of dose, right? Because you can take them a slightly different way. IV injection, look at that. You're going to have a really rapid and fast peak in your blood plasma levels, right? So we're looking at this in the blood. Makes a lot of sense. If you're injecting cocaine directly into your blood supply, then you're going to have that rapid sort of increase, right? Other ones that work is intranasal. Look at how quickly you get a nice high peak there. Smoking takes a little bit longer, but you get a decent peak. Orally, there aren't a lot of people who take cocaine orally, right? You don't see a lot of like cocaine pills out there. And I think most of you probably didn't think about taking a cocaine pill, right? If I said, hey, this guy's taking cocaine, probably one of these other methods is what's jumping to your mind, right? And if you think about why why are you taking cocaine? Because you're trying to get that high, right? And so you want that high immediately. If you look at taking something orally, that's like a 60, 70 minute wait, right? So there aren't too many people who are sitting around like, wow, I really would like a cocaine high in about an hour. I'm going to go ahead and take the pill now. Give me time to get home, get a sandwich, and then, you know, it'll hit me about the time I'm on the couch. It's not really the way these sort of things work. It's not as addictive that way. You want to take an action, and then you want to have that sort of activation of the reward pathway.
So the same thing as half-life?
This is different than half-life. Half-life is how long something's going to stay active, right, and how long it's going to take to decay and break down. This is more that initial sort of high. That's a good question. So that's why IV injections are sort of a preferred way, because you have that massive high rapidly, right? If you were to wait, you know, Jacob, what are you going to be doing in 70 minutes? Well, you know, you don't know, right? So whatever you're doing at that time, and then you're going to have this cocaine high, you're going to go, whatever that was, that's really rewarding. And so then, like, the next time you think, like, oh, man, I'm going to get a high, I'm going to go, you know, I was checking the mail at my house, right? So I'm going to go back and check the mail at my house and see if I get a cocaine. You're not, right? Because there's this massive delay. How many of you have pets? Yeah. You ever tried to train your pet to do something? Yeah. How'd that work? I mean, it does work sometimes. Sometimes it depends on what kind of pet you have. If you have like a fish, I wouldn't really. Depends on what you're training. Let's say you have a dog. You're training your dog to like go to the door, right, if it needs to go out, right? The dog goes to the door, and what do? You give it a treat, right? Because it's going out. It's going to do its thing. You don't give it a treat an hour later. The dog has no idea. What was it doing an hour later? It could have been chewing on your shoe. So you don't wait an hour to reward it. It's not going to reinforce that behavior, right? It's just basic psychology principle right there. If you want someone to change their behavior, the reward or the punishment should be tied as closely as possible to the action that you want to either have repeated or not have repeated, right? This is why you always should yell immediately at people who cut you off on the road. Because if you wait and yell at them later, then they don't know what they've done wrong. You've got to yell at them as soon as they cut you off. Again, administration is important. That's what we're going for here. How quickly can we absorb that drug and get it into the blood supply, to your bloodstream? This depends on the drug and the way that we've administered it, right? If we put it in your stomach, it can take a few hours. We put it directly into your veins, then bingo, it's there. So, we've already talked about absorption and we talked about distribution. That was kind of 2 of the 4. And we should talk about the other 2 steps, right? Metabolism and excretion. Okay, and these guys are tied together as well. Now, metabolism can get very complicated. We're not going to go too complicated with it. Essentially what happens is there are enzymes that are going to deactivate whatever drug you've taken. They will take that drug and they will break it into pieces. Those pieces will not be active, right? And then you'll be able to take those pieces and get rid of them. Now, those pieces need to be less lipid soluble than the drug itself. So what was awesome about being lipid soluble is we could slide through lipids like the blood-brain barrier. Do you know what else is made of lipids? Your kidneys, right? Because they're just made of cells, just like anything else. If something is really lipid soluble, it's going to go right through your kidneys, right? It's not going to be collected into your urine, because that's mostly how you get rid of drugs. How many of you have ever taken drugs and then your urine was a different color? How many of you have ever taken like a multivitamin? Multivitamins will do that. How many of you eat beets and sometimes your urine's a different color? Nobody eats beets. Just another example. Right? So your urine is a great way to get rid of things you don't need. Sometimes that can change the color of your urine, right? It can make it brighter or not as bright or whatever. So things need to be, once they're metabolized, they need to be less lipid soluble so your kidneys can hold on to them, send them out through your bladder, and hopefully out into a toilet. You know, sometimes it doesn't always go that way, but it's what you should aim for. Questions about that? That was kind of a short story. The metabolism story is a much longer story that I'm not really going to give you, because you don't really need to know too much. How do we know if a drug is effective? Well, you still say, well, I took a drug and it did something to me, right? But we want to measure this because that's what we do. And so we're going to look at a dose-response curve. Okay? So we're going to give you some dose of a drug and we're going to measure objectively some effect, right? Caffeine is a great example. We're going to give you some caffeine and then we're going to measure your heart rate. That's a dose, that's a response, right? That's pretty easy. I give you more caffeine, your heart rate increases more, right? Okay, so we can plot that out, right? We can get some kind of dose-response curve. We also want to think about a therapeutic index, right? Every drug that you take has a therapeutic effect. That's why you're taking it, right? So, and that therapeutic effect could even be a recreational effect, right? Whatever you're thinking of here, if it's not a like a prescribed drug. But it also has side effects, right? Morphine, for example, is really great at relieving pain. It's also really great at making you stop breathing, right? And so what we want to do is give you a dose somewhere between you don't feel pain and you stopped breathing, right? So we have to find what that is. And that's going to be our therapeutic index. How wide is that margin of safety, right? And so we really look at this. We look at what's the effective dose in 50% of the animals and what's the lethal dose in 50% of the animals that were tested with this. Now, in reality, when we go to market with a drug, it's more like a 99-1. It's not 50-50, right? Because we don't want to be like giving somebody, like, this has got a 50% chance of killing you. Have fun with it. That's probably not, I don't see a lot of people like taking that drug, right? But if I said it's got a 1% chance of killing you and a 99% chance of solving whatever problem you have, then you might take that chance, right? You think about it. You don't think about that when you take a drug, right? Like every time you take a pill, you got a 1% chance of dying. It never enters your mind, does it? It should. I hate those commercials for the asthma medications that increase the likelihood of asthma-related death. It's like, kill me from a heart attack, but if you're treating my asthma, don't let my asthma kill me. I mean, that just doesn't make any sense, right? Something else should kill you if you're taking them, and otherwise just don't take the medication. I just don't see where that helps. But what do I know? I'm trying, I'm dialing, rolling the dice on that 1% chance there. Affinity is another word we should think about. Affinity is sort of how much two things like each other, right? How well do these two things go together? In our case, how well do these two molecules join together? We're going to think about the drug, and we're going to think about a receptor site. How well do those two bind and latch onto each other, right? That's going to be really important later when we talk about competitive and non-competitive binding. We talk about agonist and antagonist. If you think about opioids, for example, you have endogenous opioids that you create inside your body. If you stump your toe, your body starts creating opioids to help alleviate that pain, right? That's awesome. You can also take opioids that are not from inside your body. Those are called drugs, right? And those can be a variety of opioids that are out there. Some of those are more naturally derived, and some of those have been specifically designed by biochemists to have a higher affinity for your opioid receptors than your endogenous opioids, right? If they had the same affinity, you got like a 50-50 chance of actually increasing your pain relief, right? So actually making that better. So you want that affinity to be higher, so when you take the drug, Sammy, you're actually seeing some improvement, right? The problem with that is they can latch on so tightly and make you feel so good that you're not going to bother to stop taking the drug. All right, here's your dose-response curve. Doesn't matter what the drug is. We're going to give you some drug. The more of it we give you, the higher your response. Now, at some point, you're going to reach a plateau. Okay? How many of you are regular caffeine users? Yeah, like everybody, right? And that's a pretty typical thing. What's like the highest dose of caffeine you've ever taken at once? 6 million milligrams. No. If you have like a Starbucks coffee, anybody know how much caffeine's in that? It can be like 400 or 500 milligrams sometimes. They're really packed with caffeine, right? But is that going to, like, what if I gave you 700 milligrams of caffeine, or I gave you 200 milligrams of caffeine? Is that going to really create much of a difference? No, there's a plateau, right? There's a certain point where it doesn't matter how much more caffeine I give you, you're not going to see a bigger change in your behavior, right? So if I'm measuring heart rate, for example, so we can just call this heart rate, and we can say this is caffeine. There's a certain point where I give you so much caffeine and your heart rate only goes so high, right? And taking more caffeine is not going to increase that heart rate anymore, right? It's going to stay where it is, so you've reached that plateau. Now, that's awesome if it's caffeine. There are other drugs that are like caffeine, like amphetamine, for example, right? Amphetamine has a plateau, but guess where that plateau is? It's like up here, right? So some drugs have higher plateaus, right? So that's going to be like a more, it's going to be a more effective dose, or a more effective drug, more powerful, potent. That's the word we want to use there. Does that make sense to everybody? It's not so bad. Here's that margin of safety. This is one for morphine. This is how much morphine you need to take to relieve your pain, and this is how much morphine you need to take to stop breathing. Okay? We want to make sure that we give you some dose of morphine. The higher the dose of morphine, if you look, at some point, this starts to overlap, right? So if we start giving you more and more morphine, eventually it increases the likelihood that you're going to stop breathing. So that's something. If the deadly curve was like right here, you probably don't want to take that drug, right? Because the margin of the safety there is pretty low. Some drugs have really wide margins of safety, right? So what's a drug that might be out here that's got a wide margin of safety? How much Advil do you have to take to kill yourself? And I don't mean like long term because you've got like toxicity, liver toxicity issues, but in the short term, anybody know how much Advil you have to take? You have to take enough to jam up your esophagus to suffocate. Because Advil's pretty safe, right? So you can take like a bunch of Advil. Another drug that's way out here is LSD. Right? I don't know if anybody's familiar with LSD. If you take the amount of LSD that you need to get high, you can actually increase that dose by 20,000 times and still not die. So I know, right? That's a pretty wide margin of safety right there, 20,000 times.
Yes, but you're more likely to kill yourself.
Well, that's on you. It's not the LSD. Cocaine doesn't have that wide of a margin, right? Anybody ever thought about taking 20,000 times more cocaine than you need to get high? I saw it on YouTube. The guy just exploded. It's not going to work, right? Because that's going to be toxic, right? At that point, it's going to cause some problems. So LSD is like the Advil of illicit drugs. Also, LSD is not addictive. That's a fun thing we'll talk about later. Should we talk about tolerance? Of course we should. You guys really irritate me, but I put up with it anyway. That's tolerance. I'm just kidding. It's not the tolerance I want to talk about. If you continue to take a drug, you have to take more of it over time to get the same effect, right? That's tolerance. We all know that, right? So why is that? Well, it all goes back to this idea of homeostasis. Okay? You have a certain operating level and you want to stay there, right? Let's assume that's where you are right now. Now, as you start taking a drug, that's going to affect your, whatever that is, right? Whatever sort of neurotransmitter level or neural activity level, whatever that is. Your body will do a couple things to adjust for that. One of those is called enzyme induction. Okay. This is a great example here is alcohol dehydrogenase. Okay. Alcohol dehydrogenase is the liver enzyme that breaks down alcohol. If you are a regular drinker, you're going to, over time, increase the amount of alcohol dehydrogenase that your liver produces, right? So that's why maybe when you started drinking, you had one beer and you're like, whoa, man, this feels awesome. After you've been drinking for a while, and I don't mean like drinking for a while that day, I mean like months, years, then you need 2 beers, 3 beers, right? 4 to get that same kind of effect, right? If you continue to drink all the time, so you should space things out. You get more, it's just cost effective, right? If you drink a bunch of beer all the time at once, it really gets expensive because you have to buy a whole bunch of it, right, to get the same effect. But if you just like space it out a little bit, saves you a lot of money. It's a better investment. And what you can do with that extra money, Caroline, is put it in an IRA account for your retirement. Then you can stop working and keep buying beer. See how brilliant that is? I know, right? Not everybody thinks of these things, but I do. That's also my pitch, so you guys don't binge drink and do stupid things. I want you to do stupid things sober, so you remember not to do them again. So alcohol dehydrogenase, you're going to increase that. That's enzyme induction. The other thing you might do is you might downregulate receptors, right? So if you start taking a bunch of cocaine over time, you're going to pull back those dopamine receptors, right? Because it's dopamine agonist. We'll talk about that later. So you're going to pull back those dopamine receptors over time. So you have fewer and fewer dopamine receptors, even though you're flooding dopamine at the synapse, right? But it's not going to have the same effect because you're pulling back those receptors. So you have to increase the dose. This also works with things like L-Dopa. L-Dopa is a precursor to dopamine, which is a treatment for Parkinson's disease, right? So if you have Parkinson's disease over time, they have to increase your L-Dopa dosage, right? Because you're still losing those dopaminergic neurons. You're losing, and there's some homeostatic things that are going on there. So you have to increase that dose, right? Now this is sort of an augmented tolerance situation because it's a neurodegenerative disorder. But it's sort of the same idea, right? You're losing sites for that dopamine. The opposite of that is like withdrawal. So when people stop using a drug, and in this case we want to think about like a drug that's really rewarding, they don't feel good, right? Okay? This is one reason people relapse so often. You've probably been taking a drug so you do feel good. And then you're going to stop taking it and you're going to feel horrible. But you know what made you feel good? Was the drug. So you'll go back and you'll take that drug again, right? So it's this continual process. It's really hard once you've started taking a drug and you're actually getting that reward pathway activated. It's really hard to stop. I mean, it's just this biological sort of process. And we'll talk a lot about this when we talk about drug addiction later in the semester. But if you think about this, you've continued to downregulate these receptors, right? You've made a whole bunch of these enzymes that are breaking down whatever, right? Whatever that neurotransmitter is. And then all of a sudden you're removing whatever was enhancing that, right? Whatever was getting that up and going. And that's going to have a really, sometimes detrimental and fatal effect, in particular with alcohol withdrawal, right? So you have delirium tremens, right? So you have DTs. These things can actually be fatal because you've spent so much time trying to compensate for the inhibitory effects of alcohol, right? So you're like trying to increase and increase and increase and increase neural activity, but you've been just artificially dropping that down through heavy and continued drinking. When you remove that inhibitor, right back up there to this like super high activity level, and you can actually cause seizures and things. Right? This is why it's not a great idea if you are trying to stop drinking and you are a heavy drinker to just quit. Right? Like all of a sudden, if you're drinking every day, that's not the way to go. You need to get some professional help and actually go through some assisted withdrawal there, because otherwise you could really cause some problems. Sometimes they'll even send you home. Like if you come in, you're like, hey, I think I want to stop drinking. They might actually not have room for you, so they'll send you home. And they won't tell you to stop drinking. They'll say, maybe I'll slow down a little bit. You probably should keep drinking enough so you don't start having seizures. It's a tricky thing to do. Hey, who loves placebo effects? You all do. Because all of your mothers kissed your knees at some point, right? And it made it feel better when you scraped it. Okay? So placebo, right? That's a placebo effect, right? You don't think about those things. Placebos are just these inactive substances that we give folks. Typically, this is going to be in a research situation, a control group. Sometimes they actually work. Sometimes they actually make you feel better. They're not supposed to, right? But sometimes it happens. This really happens a lot if we think about antidepressants. That's what we'll think about in this class. This is also a moment when I should take time and say, hey, if you're dealing with depression, anxiety, or you just want to get a $125 an hour service for free, I would recommend going to the 4th floor of this building and visiting the clinic, the psychology clinic, right? It's free to students. That's great. Normally these services would cost you really like $100, $125 an hour, right? So it's really just a great idea. If I've not made a pitch for that in this class yet, I want to let you know that is available, right? So that's cool. If they're not able to help you, they'll refer you to somebody who is. They'll get you taken care of. Because I think a lot of you know someone who's dealing with some issues, right? Anxiety, depression, whatever. quite often you don't know where to go, right? But the folks up on the 4th floor, that's where you go. They'll get you taken care of. We also have a guy, did I talk in this class about the counselor in residence? Anybody live on campus? Sean? Tom, yeah, Tom, right? So Tom's one of our guys. Is he in East? Yeah. So there's this guy, his name's Tom. You just want to sit down, you want to chat with somebody for an hour. Tom's there. I don't know when, but he's there. There's a sign, I'm sure, right, with hours. You just go in, you have a chat with him. He can get you to somebody who can help you too. That costs you exactly $0 as well, right? So that's a freebie. So there you go. That's a new thing this year, right? The counselor in residence. So Tom's the first one. So there you go. And we've got a bunch of folks upstairs who can help you out as well. So antidepressants. Why is it difficult to get an antidepressant to market? Right? It's because of placebo effects. And it's because of side effects. So if we're doing a study and we're like, hey, I've got this awesome antidepressant, I give it to this rat and he's so happy, right? And then I'm going to try to give it to, because you got to start on rats, and then we'll just give it to people. When I give it to people, maybe some of them feel better, maybe some of them don't, right? There are some side effects, so we got to worry about that. Let's say the people do feel better in general. The problem is, do they feel better than someone who got, a placebo pill? And we told them, this might make you feel better. Or the other thing they'll do sometimes is they will give you what they call talk therapy, or there's the kindly professor, right? So they'll just send you to some guy in a cardigan to chat for an hour. That's what I always imagine the kindly professor is. There's a Mr. Rogers. You go talk to Mr. Rogers for an hour, and if you feel better, that's great. There's not going to be any side effect really to that, right? It's not a side effect to chatting with someone for some time. You don't have to worry about that. The problem is a lot of antidepressants have side effects. One, typically they make you sleepy. So maybe that'll make you a little extra depressed. The other thing that most antidepressants do is they disrupt sexual function. And if that won't depress you, nothing will. Because that's a real quick way to bring somebody's mood down. Like those parts don't work anymore and you're not so interested in it. So have a good day. So antidepressants, they carry a lot of side effects. So folks are worried about that. They're not, the folks who bring these to market are conscious of that. But if the antidepressant doesn't improve your mood that much over placebo or some other already, something that's already available to you, then they're not going to be able to bring that out for you to do or to use. Two hours to go. Sites of drug action, right? We want to talk about where these drugs are doing their business. There are two broad categories of drugs. There are what we call agonists and antagonists. It's pretty straightforward. An agonist, there's this really fancy definition here. It facilitates postsynaptic effects, whatever. Basically, it increases neurotransmitter function. Doesn't matter what that neurotransmitter is, it's going to be specific. We can have a dopamine agonist. We can have a serotonin agonist. We can have an acetylcholine agonist, right? So we can have an agonist for specific neurotransmitters. It's just going to facilitate that effect. It's going to increase the effect of that neurotransmitter somehow. It's going to increase its function. There are, 5 or 10 ways this can happen. We'll talk about those. Okay, so don't worry about it. It's just going to increase. It can happen a lot of ways, right? So who are the athletes again? We have athletes. All right, what sport? Softball. So what's a great agonist for a softball team are gloves, right? Because that's going to help you. That's one way we could help. Cleats, that's helpful. That's a different way. Maybe a coach, right? I don't know. I've played on softball teams that didn't have a coach, right? So those were fun intramural teams. We were obviously not very good. Super story. We had a great time, though. I think that's what mattered. We accidentally made the playoffs that year. Yeah. I mean, we won enough games, but we have no idea how. Because we had a third base coach who was some random guy we all knew who didn't even go to school with us. He would just show up and he stood at third base. You guys have intramural softball here? Yeah, that's fine. Antagonists. What are things that might inhibit, right? So we're going to decrease neurotransmitter function. What are those things? If you're on a softball team, blindfolds, right? That's probably gonna hurt your performance, right? Selfish teammates, those are always great. Always get a selfish teammate if you can. No, those are going to hurt performance as well, right? So there are all kinds of ways that we can increase, all kinds of ways we can decrease neurotransmitter function. So what's one of those ways? Well, what about production? All right, we can affect the production of neurotransmitters, right? We can provide you with precursors. We talked about L-DOPA. That's a precursor to dopamine, right? So what if we were to give you more L-DOPA, right? Then you're going to be able to build more dopamine. That makes sense, right? What if we were to, still thinking about dopamine, there's something called tyrosine hydroxylase. That's an enzyme that takes L-DOPA and turns it into dopamine. What if we were to increase how much tyrosine hydroxylase you have? What if we were to increase its function, right? So we were to make it work more rapidly, then that's going to affect production. What about storage? We have to put all of those neurotransmitters in vesicles. You guys remember that, right? What if we disrupt that? We can actually block vesicle transport, right? So all of those vesicles are going to stay docked and none of them are going to be released to drop out the neurotransmitter at the synapse, right? So that's obviously going to be an antagonist, right? So we're going to prevent that from happening. There are other things we could do that actually could increase release, right, of the neurotransmitter. That's kind of interesting. Some of them stop that. Who loves botulism? All right, everybody loves botulism, right? If you want, dry armpits, a tight face, and no headaches, botulism's the way to go. They use botulism to treat migraines now, so that's the headache thing. It's been used for a number of years cosmetically, right? For like paralyzing your face. So if you like the way your face looks now, put a little botulism in there. Yeah, when your mom told you like don't make that face or it'll be stuck that way. If she'd had some botulism, next time she does that, say if you got some botulism on you, you might be telling the truth. And then they also use Botox to kill to paralyze the sweat glands in your armpits, so you don't have sweaty armpits then. I don't know if anybody's interested in any of those. You don't have to raise your hand. Nobody's going to raise their hand if they're interested. If they're interested in the sweaty armpits, right? Put both arms up like a touchdown. So there you go. That's alcohol. That'll actually increase the release of GABA. This is a fuzz. You can't see this here, but it's in your book. This is actually cool. It shows you all of the ways that agonists or antagonists can affect neurotransmitters, right? So all of the places of action. So whether that's in creating, storage, release, whatever. Other things that we can do is we can actually block receptors or we can stimulate receptors. So we have something called a direct agonist, we have receptor blockers and non-competitive binding. So we should think about this just a moment. If it's a direct agonist or a direct antagonist, this drug is going to bind exactly where the neurotransmitter binds. So it's going to mimic the neurotransmitter, right? It's going to lock into the same site. It's going to open that ion channel or it's going to close that ion channel, right? It's going to do one of those two things if it's direct. We call this competitive binding. Why? Because the neurotransmitter and the drug, either agonist or antagonist, are both competing for the same location, right? So they're both competing for that same site. So it's competitive. On the other side, we have what are called indirect agonists or antagonists. In this case, the drug is binding somewhere else, right? It's not binding to the neurotransmitter site. The neurotransmitter is still there, doesn't really matter, but the drug is going to bind somewhere else. This is what we call non-competitive binding. No one else is trying to get to that other site except the drug you've taken, right? So the other drug will bind to that additional site and it will have its action in that way. So it'll open or close the ion channel. What about reuptake or destruction? There are two ways to get rid of a neurotransmitter. You've got to reuptake that neurotransmitter, or you've got to destroy it with an enzyme, right? So if we think about SSRIs, for example, that's a selective serotonin reuptake inhibitor. Normally when you release serotonin, that's abbreviated 5-HT, you're going to recycle that back into that cell that released it after some time. If you block that process, you're going to leave serotonin at the synapse for a longer period of time to do its effect. So in this case, we're thinking about an agonist, right? Because we want to increase serotonin levels. Neurotransmitter, enzymatic degradation. We can increase that or block that depending on whether or not we affect. One of those is like MAOIs, right? Monoamine oxidase inhibitors. These are enzymes that break down monoamines, like dopamine, for example. And if you inhibit that enzyme that breaks down dopamine, guess what you get? More dopamine, right? Because you're not breaking it down anymore. So MAOIs you got to worry about because you can't eat cheese or drink wine if you're on one of those. So that really knocks out two of your major food groups, right? You guys look like a bunch of wine drinkers and cheese eaters. Sammy, that got you excited. You love a good slice of Gouda, I can tell. Oh no. I got this new refrigerator, and I put my cheese in this drawer that says cool drawer, but it's right next to the freezer on the bottom, and it froze all my cheese. I was really upset about that. Yeah, I know, right? Froze my bacon too. I wasn't so upset about that because I was like, whatever. But cheese, you can't really. There's not much you can do once it's frozen. Thankfully, it wasn't very good cheese. Put the good cheese somewhere else. If we want to think about neurotransmitters, what are some of the ones we want to think about? Glutamate is going to be an excitatory neurotransmitter. It's going to have NMDA and AMPA receptors. We'll talk about those in particular when we talk about learning and memory. That's going to be fun. GABA is pretty cool too. That's an inhibitory neurotransmitter. It's actually made from glutamate with this guy called glutamic acid decarboxylase, right? Which basically takes glutamic acid and knocks off a carboxylase. And I know that probably made no more sense than the first time I said it, but essentially it takes glutamic acid and chops off a piece to make GABA, which stands for gamma-aminobutyric acid. Hey, who loves benzodiazepines? You don't have to answer that. Those are GABA agonists, right? Have you ever seen someone who's on a benzodiazepine? They look like they're asleep because their GABA is turned on. You should not be on a benzodiazepine more than 6 minutes, right? It's not a long-term solution. It's an immediate solution for sort of a catastrophic or violent situation, right? It's not for something else. There's some other neurotransmitters, acetylcholine, learning, memory, REM sleep. We'll talk about that when we get there. Dopamine. Dopamine does all kinds of stuff. Voluntary movements, attention, learning, problem solving, planning, reinforcement. We'll talk about dopamine systems as we get there, as we need that.
Say that A word again.
Acetylcholine. It's also used for muscle contraction out in the peripheral nervous system.
And killing people and not being able to trace.
Not so interested in that, but thanks. We know where to go if we need somebody rubbed out and we don't want to know who did it. Bobby's your person. Norepinephrine and epinephrine, these are for cortical vigilance. They also get your heart rate going. Serotonin is great. Mood regulation, eating, sleeping, other things, impulse control, right? That's why we give SSRIs to folks who are have problems with impulse control. Histamine, wakefulness, we'll talk about that in the sleep chapter. How many of you have ever taken Benadryl and then you took a nap? Yeah, that's usually how that goes. There might be a small number of you who take Benadryl and then run a marathon. Some folks, Benadryl works the other way. It happens occasionally. Opioids, that's for pain modulation and reinforcement. Endocannabinoids, interestingly, for that cannabis trip that you took, appetite regulation, right? This is why they will prescribe marijuana to some individuals who have like wasting disease, right? So anytime you have a disorder that's going to cause you to lose a lot of weight, maybe you're not really interested in eating, right? Maybe you're on heavy-duty chemotherapy treatments, right? That's not going to make you very hungry. Not really going to be interested in food. A good dose of marijuana will actually, make you hungry, and you'll eat and try to keep up some weight, and it's going to be better for your health. That makes some sense, right? Let's see. Here's your NMDA receptor. Not much here to really think about. Blocked with magnesium. We'll talk about NMDA receptors a lot when we get to learning and memory. Here's your GABA receptor. This is interesting. So GABA will bind here, but you've also got spots where benzodiazepines or alcohol, for example, will bind that are not going to be that site. So those are going to be non-competitive, right? Because they're going to bind to different sites, not the neurotransmitter site. I don't expect you to get too much out of this. This is a rat brain. I just want you to know basically these systems send information sort of everywhere, right? So for acetylcholine, you've got stuff going up to cortex, amygdala, all kinds of places. If you take a drug that increases or decreases acetylcholine levels, it's going to have that effect sort of everywhere in the brain, right? We're not going to be able to specifically target one place where we want to increase or one place where we want to decrease. Here's a biochemical pathway for making acetylcholine and for breaking down acetylcholine, right? Keep in mind that this is just for acetylcholine esterase, so we can think about that in terms of agonist or antagonist. Here are some drugs that affect acetylcholine. We already talked about botulism, right? Who loves black widow spider venom? It's always something you should keep on hand. That'll actually cause the release of acetylcholine. You'll have a bunch of convulsions and then die because you'll exhaust all of the acetylcholine that you have, and then you're kind of finished there. Dopamine. Do we want to talk about dopamine now? Actually, dopamine's story is going to take a while. What I'd like to do is stop here at dopamine, let you guys have a little mental break, and so you can just sit here and stare at me for the next 16 minutes. Does that work for everybody? Because I don't want to get into that news story right now, because I'm